Hello, I'm Aaron Lohr, host of the Endocrine News podcast. In addition to bringing you the latest research breakthroughs and clinical advances from experts in the field, we talk about education, advocacy, career growth, and more from the endocrine perspective. From bench to bedside, from graduate school to practice, from the doctor's office to Capitol Hill, we talk about it all, and it's free to you. So go to www.endocrine.org/podcast or search for Endocrine News Podcast on Apple, Google, or wherever you get your podcasts.
This is Endocrine Feedback Loop. I am your host, Chase Hendrickson, and welcome you to this Journal Club podcast series brought to you by Endocrine Society. Thanks for joining us as we explore an important article recently published in one of the Society's clinical journals. Hello, and welcome again to the Endocrine Feedback Loop podcast for our 30th episode. For this episode, we return to the JCE&M to review a clinical trial of medical management for Cushing disease. Cushing syndrome remains one of the most challenging conditions for us as endocrinologists to diagnose and treat, and this article will help us understand what new approaches are available to us. We've only reviewed a few clinical trials for this podcast, and so we'll be sure to review key aspects of the methodology for these studies. I continue to be lucky to get to host the Endocrine Feedback Loop. I work at Vanderbilt University in Nashville, Tennessee, where I am a general endocrinologist, the medical director for our endocrine clinics, and an associate director for our fellowship program. Back yet again today as our regular contributor is Katie Gutenberg. She comes to us from the University of Texas at Houston, where she is the director for their endocrinology fellowship. She focuses her clinical practice on pituitary disease and is a master educator at McGovern Medical School, teaching extensively there. Our guest expert today is Maria Flasheriu, professor of medicine and neurological surgery from the Oregon Health and Science University in Portland, where she directs the Pituitary Center and the Pituitary Disease Fellowship. She is known to you all as one of the world's experts in pituitary and adrenal disease, particularly glucocorticoid disorders, with extensive research and clinical expertise in these areas. Though not an author on the report we will look at, she participated in all the osilodrostat trials and so is nicely situated to comment on this one. So for a study of Cushing disease, I am joined by an ideal pair of endocrinologists. As always, everything we say is our opinions only and not those of our respective institutions or the Endocrine Society. Today, we review randomized trial of osilodrostat for the treatment of Cushing disease. The Journal of Clinical Endocrinology and Metabolism published this article in July 2022 with Monica Gadelha from Universidad Federal de Rio de Janeiro as the first author, as well as several authors from different institutions around the world. Now, I will turn things over to Katie to go through the author's introduction to their work. Along the way, she and Maria will also help us understand key aspects of Cushing disease and its treatment. Katie?
Thanks, Chase. So transfemoral surgery, as we know, is the first-line therapy for most patients with Cushing's disease. However, up to a third of patients do not achieve sustained remission after pituitary surgery and require additional treatment. Options include repeat pituitary surgery, medical therapy, radiation therapy, and bilateral adrenalectomy. And despite multiple treatment options, many patients do not achieve or maintain normal cortisol excretion. So, I think Cushing's disease is one of the most challenging conditions that many endocrinologists treat. So, Maria, I'll ask you just to start by describing why curing Cushing's disease is so challenging and what options exist for those who fail an initial surgery.
Thank you for the invitation to discuss Cushing's treatment in general, and it's a pleasure to be here. However, your question is very complex, and unfortunately, due to the delayed diagnosis, as you mentioned, patients with Cushing's are frequently not cured by the initial surgery, and on top of that, almost 25 to 30% will recur. So we have half of the patients with Cushing's requiring second-line treatment. Now, which is the second-line treatment that would be the best for each patient? That's the push towards more individualized treatment. Sometimes we do second surgery. However, second surgery, especially if the first one was done in a specialized pituitary center, is not going to work to cure the patient. but the risk of hypopituitarism could be up to 50%. So we have to address this when we talk to the patients. For larger tumors, usually I go to second surgery just to do more debulking of the tumor. Though they are rare, they could be more aggressive. Medications, we started with no medications approved in US. And since 2012, we have now 4. And about 1 we're going to discuss in detail the latest studies. So each of the medications work differently. The mechanism of action could be different, and we'll talk about that later. How rapid the drug will work, how tolerable is for the patient, how easy to use. Is it oral? Is it injectable? And then I like to know in advance how probable is for that drug to work. So keep in mind that we know that some patients will respond and some patients won't respond. Which one will respond to which medication? That's not very well known, though we have some idea. Local availability, cost of the drug, access, all of these are in my mind when we talk about medications. Now, radiation therapy is third line or second line for some patients. Exactly where it places in the treatment algorithm, and we have discussed this in detail in the latest consensus Cushing's meeting, is also based on how many medications we have available. And on top of that, depends on centers and countries. If they don't have access to a specialized surgeon, if they don't have access to any of the medications, then yes, the patient would be a good candidate for doing radiation as a second line. However, the radiation, even the stereotactic, newer one, does not cure all the patients. And again, the risk of hypopituitarism grows with every year. Some patients will develop hypopituitarism even 10 years or later. So everything in Cushing's treatment, like in life, is a balance. Also, we have used for many, many years, and I'm still using now, bilateral adrenalectomy. So for patients with Cushing's disease, we try to use it as a last resort, with one exception in my mind. If it's a patient that's a young woman that wants to get pregnant, this is probably the best treatment to achieve quick normalization of hypercortisolism. Yes, we change a disease from Cushing's disease to permanent adrenal insufficiency. It exists risk of corticotroph tumor progression, but we give that woman the chance of having a normal pregnancy and also a normal child, and we definitely follow very closely after that. So overall, we have many, many options, and each patient is different, and we should look at the right treatment to be individualized for each patient. And I have to say, when you said challenging, the challenging part is that several patients are actually requiring all these treatments that I mentioned: surgery, repeat surgery, radiation. And if they are not controlled with medication, luckily now with so many options, it's more rare, then they end up having bilateral adrenalectomy. So overall, we should push for an earlier diagnosis with less complications and less severe disease, but that's the topic of another discussion for more than an hour, to say the least.
Thank you. That's a really great overview. So the current study, as we know, focuses on elidrostat, which is a potent oral inhibitor of 11-beta hydroxylase. So maybe you can just comment, Maria, also a little bit more about the mechanism of action of this drug.
The mechanism of action of elidrostat is relatively similar to the older drug that's not approved in US, a potent oral inhibitor of 11-beta hydroxylase. There are very few studies, and I haven't mentioned earlier, that compare the drugs in between. So all these numbers that you are going to hear from us, and some drug is potent, some is not potent, they are going to be related to each individual studies. So without comparative studies, it's hard to say, and luckily we have some that's against placebo, it's hard to say exactly how potent would be, looking that some studies had different inclusion criteria, some were prospective, some were retrospective. However, based on the data we have right now, we can say that elidrostat is a potent oral inhibitor of 11-beta hydroxylase, also of aldosterone synthase. So why it's important to know the mechanism of action? One, to differentiate the adrenal steroidogenesis inhibitors from the other drugs. So elidrostat, like many other drugs that we're going to hear later, are adrenal steroidogenesis inhibitors. So what does this mean? Means that it's blocking the cortisol secretion at the adrenal level. So this is Cushing's disease we're talking about. So it's not addressing the ACTH. And when it's blocking the 11-beta hydroxylase, we have to remember that, yes, it's blocking the cortisol production, but what's going to happen with the things above the cortisol? They are going to go up. So we're expecting the precursors as DOC11-deoxycortisol to go up. So we know that through the mechanism of action, these precursors will increase. Also, we'll see increase in some of the androgens, and this is important for clinical action. Overall, knowing the mechanism, it's helping us understand the possibly adverse effects. Every patient is different. Some will have hypokalemia, some will have hyperkalemia, and you will start thinking, blocking the cortisol secretion and aldosterone, you should have hypokalemia. Yeah, but some precursors could act differently, and you still have some glucocorticoid excess per se. So patients have to be followed closely, but it's nice to know, and I look at this of all the drugs that I'm using, especially for Cushing's, they have so many complications that we have to follow closely. And for each drug, I have some things that I'm following maybe more closely than others. And for osilotastat, I'm going by mechanism of action because otherwise it's a well-tolerated drug.
So we'll move on to the current study. So the current phase 3 trial has 2 parts, an initial randomized double-blind period of 12 weeks to compare the efficacy of elidrostat against placebo. And then this was followed by a 36-week open label period to evaluate the sustained effect of elidrostat and long-term safety. So with that, I will hand it over to Chase, who will walk us through the methods.
Katie, thank you for walking us through that introduction, and Maria for your comments as well. So what we're going to do is, as we normally do, we'll think about the study design in general, and a reason in particular to do that today is that most of the studies we look at are observational studies. And when we do that, confounders are one of the biggest things that we wrestle with, trying to figure out what else might be driving the outcome that we're looking at. The reason that RCTs are considered the gold standard for investigating, particularly medications, is that it helps with that. And the way that it does that by randomizing subjects. So there are still potential confounders that are at play, but by randomizing which subjects get into which groups, it balances out those confounders. So an informal way of thinking about it is that they cancel each other out. They don't go away, but it's not going to affect one group more than another if the randomization is done correctly. The other strength of these is that when they're blinded, as this study was in that initial phase, then it removes biases. We've talked about this before, but in biomedical research, a bias is often how we use that term in other settings, is we're treating one group of individuals different than another group of individuals. It's not in biomedical research typically done on purpose or maliciously, anything like that. So there's not the negative connotations there, but it can affect the results. And it can be the subjects themselves knowing that they're taking something or not taking something that can bias how they view that. So the real benefit of blinding is that, well, you can't treat somebody differently based on the group they're in if you don't know what group they're in. So that's the real strength here. Now that does go away when you move from a blinded period to an open label period, to where that blinding goes away, then you do introduce some of those. So you do have to be careful when you transition from one period to another. Some of those strengths, while initially present in that first period, will potentially go away depending on which ones you're talking about, in particular the subjective ones. So we'll need to think about that as we consider the different parts of this study. When we think about drug trials, there are different ways of describing the phases of drug trials, and they go up in numerical order, and sometimes you can even have preclinical ones. But when you start talking about clinical drug trials, phase 1 studies are very, very small. Those are attempting to understand what the right doses that you should be using. And then phase 2, you start expanding that to try to understand what the efficacy might look like and getting more safety data. This is a phase 3 trial. And with phase 3, that's where you really start comparing it to try to get hard data to understand, is this medication or whatever other intervention is being studied superior or at least as good as anything else that you're taking a look at. Phase 4 trials, which are later on, this is after a medication is approved and it's been out, and that gives you a much better sense of the rarer side effects that may not show up until you've had thousands of individuals on a drug. And so that's something that would come after a drug is approved. But that gives us a sense of where we're at now. So back to this study, Katie walked us through just the very basics of of that. So we'll really take a much deeper dive into the methodology here. So the eligible patients, so a broad range of ages, it could be 18 to 75, and you had to have a confirmed diagnosis of Cushing disease. And we're going to walk through that, and then I'm going to get Maria's thoughts on that. But first of all, as far as the mean urinary free cortisol, that's the main measurement that's used repeatedly here. To have that diagnosis, that had to be more than 1.3 times the upper limit of normal. You also had to have an ACTH that was above the lower limit of normal. And then in addition to that, you had to have one of several different criteria. One was an adenoma that was visible on MRI that was greater than 6 millimeters. If you had an IPSS that was done, you had to have that central to peripheral gradient be 2, if that more than 2 if it was a pre-dose, or if you use CRH or DDAVP, it had to be more than 3 after that. Or for those who had had a surgery already, you had to have had histopathological confirmation of an ACTH producing pituitary tumor. Any of those combinations would get you there. So Maria, help us understand that. Do you see a lot of these patients, you use these sorts of criteria to figure out who has Cushing and what type they have? Does this strike you as a reasonable way, or do you have any worry here that this might have misclassified folks as having or not having disease or subtyping it?
This is a very well-designed study. It's relatively similar with few exceptions. First, for a study, it's a little bit different than clinical care. You have to be sure that the patients that are enrolled in a study have the disease that the drug or whatever other treatment is studied for. So some of the criteria you see here, not the UFC particular, evidence of an adenoma, IPSS with ratio specifically for Cushing's disease, or histological confirmation of an ACTH producing tumor. All these go back to really including patients that have Cushing's disease. And as you know, sometimes ectopic Cushing's could look without IPSS, can respond to high-dose DEX and could look like Cushing's disease. So if the patient had pituitary surgery and was not cured and didn't have histopathological confirmation, then we really don't know if this was Cushing's disease. So these were very strict criteria to make sure, and this has been done in all the Cushing's trials for Cushing's disease. Now, in addition to that, one of the inclusion criteria that you mentioned, it's a little bit different compared with other study, is the mean UFC. So there are 2 points that I want to make, that sometimes we don't do that in clinical care because not all the patients like to collect several 24-hour urinary free cortisol, and I completely understand. We know from earlier studies that also were some study on treatment, but we looked at the baseline. The variation in urinary free cortisol could be 50% from one day to the other in patients with Cushing's. And the lower the cortisol, if they have mild Cushing's, especially with recurrence, or in patients that had surgery and they just are not remitted. So we need at least 2 or 3, usually for studies are 3 in most, in very few we did 4, to actually know for sure that the patient has active Cushing's. Now, in clinic, I would consider that a patient that has abnormal salivary cortisol and an elevated UFC, this patient, I would say, has persistent disease. However, for studies, you really want to have strict criteria, and mean UFC was more than 1.3, so mild Cushing's, and this is important to discuss about that, compared with other studies that had 1.5. But all patients had to have confirmed Cushing's, and this goes back to the idea that we know in the end, as you said, for all these studies, especially when it's compared with placebo, that this is not a patient with what we used to call before pseudo-Cushing's or cyclic Cushing's or any other potentially confounders in the inclusion criteria.
Thank you. That's helpful. And we're going to come back to thinking about some of those differences in what we see in clinical trials, and those are being very rigorous with lots expected of the subjects, and sometimes not being able to accomplish that in clinical care. So that's going to come up as we think about the monitoring here, and in particular as we apply that to our clinical practices. So we're going to come back to that here in the future. Another word on patients that were included is that it was an option is if you had been on medical therapies, other medical therapies for Cushing disease, and they really looked at the host of the ones that were available available at the time, that you were eligible for this study as long as you went through an appropriate washout period so that we wouldn't see any residual effects of the previous medical therapy. Now, there were some exclusion criteria, and I'm going to get Maria's comments on this to help us understand why in particular these folks were excluded, because I think that's really helpful to understand how to apply that to our patients. But the list of them, so if you had the stereotactic radiosurgery within the past 2 years, or fractionated radiotherapy within the past 3, those were both exclusion criteria, as was having recently had pituitary surgery, meaning within the past 3 months, or if you had a pituitary tumor that was causing optic chiasm compression or was considered to be at a high risk for doing so. So Maria, help us understand, why did they exclude those folks, and so that we can then apply that to our patients that we see?
That's very interesting that in a study, and you are correct, there are differences. A patient that had radiation, and I know they need treatment, I will start treating them with bridge medical therapy immediately, regardless of when they had radiation. However, for a study, you have to make sure that you do not see the effects of the radiation throughout the duration of the study. And I mentioned briefly earlier that stereotactic radiosurgery doesn't seem to be better efficacy, though some studies show maybe, than fractionated radiotherapy, but works faster. So was decided that the stereotactic radiosurgery would expect in 2 years to see some results. And then for fractionated in 3 years, the timelines could be longer. Here also, when you stop the drug, you would see going back, and in some previous studies we did that because this is a rare disease. I really liked when you said for phase 4 that to look at thousands of patients. For Cushing's, we'll never get to thousands of patients. However, this would be very nice to have multi-center international trials that go to thousands. But I diverted, but that's very important to know the difference between studies and clinic. However, this is very important, and I do this in clinic too. If a patient had pituitary surgery, even if I think that the patient is not in remission yet, that the cortisol values are higher, in the first few weeks, maybe I wouldn't wait 3 months in real life, we know that the patients could have delayed remission, and some studies show between 6 and 10%. So rushing to a treatment would not help in clinic either. Here, the 3 months was done for the cleanness of the inclusion criteria and thus exclusion from the study, to know for sure that this is not a delayed effect of surgery. The most important one, and this is something that I do the same thing in clinic, if the patient still has a large tumor, macroadenomas are rare in Cushing's, most of them are micros, but as we all know from patients that we are seeing every day, the patients that have large macroadenomas most of the time are aggressive and coming back. So for a patient that has a tumor that's close to the optic chiasm, I don't know if it's a drug or the natural progression, and most of the studies were not able for any of the drugs to answer this question very precise. However, I'm worried that if I'm using a drug that doesn't work at the pituitary level, as I mentioned earlier, the mechanism of action is very important when we choose a drug versus the other. Osilodostrate for this study, but all the adrenal steroidogenesis inhibitors and the glucocorticoid receptor blockers for that matter do not work at the pituitary level. So blocking the cortisol or the glucocorticoid receptor, what happens is going to be a lack of feedback. So we are feeling much better now that it's not really a corticotroph tumor progression so advanced as in bilateral adrenalectomy, the former Nelson syndrome. However, we have seen that some of these tumors can grow. So for a study, you do not want to have patients that already it's touching the optic chiasm, or this is an aggressive tumor, because then you cannot really use the drug safely. And this would not be, even if that exclusion criteria would not have been there, I would never enroll the patient in a study with a drug that's not working at the pituitary level. Sometimes we have to use combinations for these patients. So again, in real life, we're stuck and we have to treat them. In a study where you can say, I'm not enrolling, but what you do with these patients in clinic. So you have to use meds while you're doing radiation, but then I prefer to use either combination or pituitary-directed drugs.
Thank you. That's helpful. And a few more words here on the method. So in particular about randomization, mentioned that's a key part of clinical trials. And with this, there was an assignment, a 2-to-1 assignment to treatment versus placebo. So this is frequently done, and this is something that you can do. It helps encourage subjects to enroll if they know that they're twice as likely to get an active medication as a placebo, but then you're able to do it with having minimal impact on the power, meaning you don't need to enroll a lot of additional patients or subjects to help make up for that. They also stratified them by whether they had been irradiated in the past. And when we saw there was exclusion criteria, if you had recently had that for a more distant past, they did that to ensure that they had equal folks in those two groups. So to review the procedure that was done here. So during that initial phase, that randomized double-blind placebo-controlled period, there were independent endocrinologists who determined dose adjustments. That was primarily based on the urine-free cortisol. They looked at those at weeks 2, 5, and 8. There were some other data that they reviewed. So those individuals were not blinded, though the subjects were, and also the investigators who were interacting with the subjects. And the way the dose titration worked is the starting dose was 2 milligrams twice daily, and then that was increased as needed to 5 twice daily, 10 twice daily, and then up to 20 milligrams twice daily. And that during the double-blind period was the max, though during the open-label period that came afterwards, you could go up to 30. It was also possible that if it was necessary to reduce the dose, so even though they started at 2 milligrams twice daily, you could be reduced below that if needed. And the individuals who were receiving the placebo, the subjects who were not in the active group, did have a dummy titration schedule to maintain that blinding so that they wouldn't know from that alone which group that they were in. And then after that transition, so when they went from the blinded period to the open label period, so all patients restarted with that, and that was weeks 13 to 48. They all started with ozolidrostat 2 milligrams twice daily, unless they were on the active one before and then had been previously reduced. So as far as the study endpoints in the assessment, the primary objective was to determine whether the medication ozolidrostat was superior to placebo in normalizing the average, the mean urine-free cortisol at week 12. There were several secondary endpoints. The key secondary endpoint was the proportion of patients achieving a normal mean UFC at week 36. And so that's the combination of both arms there after that open label treatment for 24 weeks. And as I said, there were numerous other secondary endpoints, and some of them were subjective. We're not going to focus on those. We're going to look at most of the other ones in detail here. But I do think it is important to note that the subjective ones are going to be affected with the open label when individuals know whether or not they are taking the active medication, or in this case that they all are. And then finally, on the statistical analysis, there was a power calculation done. I mentioned that earlier. And with that, they determined that they would need 63 subjects to see a difference here. And then to account for dropouts, they aimed for 69 individuals here. And they also determined up front that they would be describing the differences between these two groups as an odds ratio. And I'll merely mention as an aside that struck me as somewhat atypical. Usually in RCTs, that a risk ratio is used, a relative risk is used. And that's a little bit more intuitive when we think about statistics and trying to compare groups. That risk is a bit more natural way for us to think about that. Odds are still things that can be used. It's still an acceptable statistical approach to describing differences between two groups. But for outcomes that are fairly common, it can make that absolute number be much higher than if you looked at the comparative relative risk. So we'll look at those numbers and give some different thoughts there as we go along. But that's an overview of the methodology here. So now we're going to go back through. Katie's got a lot of work. There's a lot of data in this paper, so we're going to focus on the key data here, and she's going to walk us through that, and Maria's going to continue to help us understand that as we go along. Katie?
So starting with the patient characteristics, 73 patients participated in the study. There was a very small number of dropouts. So during the 12-week placebo-controlled period, 3 patients discontinued all from the olidrostat group, and then 5 patients discontinued during the open label treatment period. Looking at some of the specific characteristics, the median time since diagnosis of Cushing's disease was about 5.5 years, and we're talking about all of the patients in the study. The majority, as expected, were female, so 84% of participants. The majority, 88%, had a previous pituitary surgery. 62% had received previous medical therapy. 12% had received previous radiation, and the baseline urine-free cortisol was 3.1 times the upper limit of normal. And Maria, I'll ask you to comment on the implications of these characteristics of this population.
This population is pretty characteristic for a study. I have to say that in clinic, some patients will be cured by surgery and they don't have to go through several medical therapies and radiation and then go to another treatment. So in general, all the studies are selecting patients that have not done well with other treatments. So we have to keep in mind when we look at the numbers that these were more severe patients. And the baseline UFC tells you that. The inclusion criteria was mean UFC more than 1.3. This baseline UFC was 3.1 of upper limit of normal. So these patients were significantly more severe than the lower level of for inclusion criteria. Now, compared with other studies, actually, they were not even so high. There were studies, for example, the one on levoketoconazole looked at data that patients had UFC more than 5 times upper limit of normal. And they're comparing, for example, with that study, 70% of patients did not have surgery before. That was Cushing syndrome in general, not just Cushing's disease, but in general, these were patients that had more pituitary surgery than others and relatively lower UFC compared with other studies, including avosilodostat. In some of the initial studies, we had patients that had 10 times upper limit of normal. So overall, this was the last study. When you look at placebo, that's also something that goes through everybody's mind. Regardless, of course, you offer to everybody. But if it's a study with placebo, a patient with very severe Cushing's that we all see in the hospital, with very high urines, with a lot of complications that we didn't even have time to talk about, this is not a patient to go in a study that potentially, even for a few weeks, will go on placebo. So important is females, mostly with Cushing's disease, that's matching. They had a disease for a while. So the 67 months is very important when we looked at the clinical improvement. And this is for all the studies. We know that some complications and features will improve, some will disappear, some will persist. And then we need to closely follow, because there are patients with more severe disease that sometimes we see in clinic, that they failed other therapies.
So moving on to efficacy, looking at the outcomes of this study, the proportion of patients achieving a normal urine-free cortisol at 12 weeks was significantly higher as expected among the patients receiving alidrostat, with 77% of patients achieving a normal urine-free cortisol compared to 8% of patients receiving placebo, with an estimated odds ratio of 43. And I know, Chase, you previously commented on this in terms of the difference between odds ratio and relative risk, and I'll ask you to comment on that again.
Yeah, and this is just a quick calculation that I did. But if you did a relative risk here, 10 would be a closer number, saying it's 10 times more likely that you're going to get control with the medicine as opposed to not being treated. I don't know that it's a big difference because it's a striking number either way, but I do think it helps illustrate that odds ratios with a common occurrence, they are much higher numbers. So this is in the 40s, the relative risk is in the 10s. So I think probably more helpful to say you're 10 times more likely to get control on the medicine as opposed to not taking it, though odds ratio is still an acceptable way of describing that.
Thank you. And then moving on to the key secondary endpoints. So just to remind everybody what that was. So that was achieving normal urine-free cortisol at the end of the open label treatment period, and that was achieved in 80% of patients. It took on average about 35 days for patients to achieve a normal urine-free cortisol. And then looking specifically at patients with severe hypercortisolism, so baseline urine-free cortisol greater than 5 times the upper limit of normal, at week 12, osilodrostat had normalized urine-free cortisol in 6 out of 8 of those patients. At week 48, 84% of patients with normal urine-free cortisol were receiving doses of less than 10 milligrams per day. So now we'll talk about safety and tolerability. The most common adverse events during the placebo-controlled period included decreased appetite, arthralgias, and nausea, and only 1 patient discontinued because of an adverse event. During the 12-week placebo-controlled period, 14% of patients receiving osilodrostat experienced an adverse event related to adrenal insufficiency. And a couple of things to point out related to that. Adrenal insufficiency was an investigator-reported adverse event based on their clinical judgment. There was no protocol-mandated requirement for adrenal insufficiency to be confirmed by measurement of serum cortisol. And so, Maria, I'll just stop there and ask you to comment on your approach and assessment, both in terms of clinical evaluation and biochemical evaluation for adrenal insufficiency in these patients.
Thank you, Katie. In addition to diagnosis of Cushing's, I think this is the second most complicated diagnosis of adrenal insufficiency of a patient on medical therapy for Cushing's. And the reason is, when the patients have Cushing's, as I said earlier, for many, many months or years, the moment you decrease their cortisol, they will also have some withdrawal symptoms. And the duration of those symptoms, and sometimes it's related to treatment or could not be related to treatment. We see this after surgery with abrupt decrease, but sometimes they don't have so much after surgery. And then because it's going down from 10 times upper limit of normal to 5 times upper limit of normal. And then when you really normalize it, that's when they have severe withdrawal. Now, the point that was in this study and in all the studies, and also in clinic, if a patient is on a medication for Cushing's, and they call you that they have symptoms, yes, I want to have a morning cortisol. That would be ideal. But if the patient is not feeling well, the likelihood of getting a morning cortisol is very low because I want to treat that symptom because I don't know if it's adrenal insufficiency or not. So in my mind, for study, you can take this chance. So of course you are going to treat. In clinical practice, what I do for a patient, but also I have the luxury of knowing the patients for months and years. So I know if they went through withdrawal after surgery, I know more of their symptoms. I'm asking if it's somebody sick around. So how I usually do it, everybody that's on adrenal steroidogenesis inhibitor, but also other drugs for Cushing's, but adrenal steroidogenesis inhibitors are very potent. So I'm expecting more adrenal insufficiency. They leave my clinic also with a prescription for hydrocortisone to have at home, PRN, and also with stress dose steroids. Injectable, the same thing as we do for the regular patients with adrenal insufficiency. When they call with symptoms, the first thing I do is I stop the drug for Cushing's if there are mild symptoms, or decrease the dose if I think it's withdrawal. What I think it's withdrawal might actually be mild adrenal insufficiency. As we know, it's nothing that differentiates. Of course, if they have low blood pressure or vomiting, then we go to adrenal insufficiency regardless. But some mild nausea, abdominal pain, muscle pain, that could just be withdrawal. That being said, in the studies, a lot of these patients, the symptoms overall could be compatible with adrenal insufficiency, and they were counted as that. For this particular study, I have been part of the study, but not part of the paper per se. But I can tell you for all the other studies, both for osilodrostat and for other drugs that I have participated in, you want to count everything. In a trial, you want to err on the side, especially for safety. If the patient has headache and nausea, I would say this is potentially compatible with adrenal insufficiency rather than say withdrawal, it's nothing. So in clinic, we have a little bit less adverse events just because we don't, as we all know, we don't count every symptom that a patient has separately. I just put in my notes that the patient didn't really feel well. I had to decrease the dose. They have steroids on hand. And if somebody gets sick in their family, we'll start the hydrocortisone and stop the osilodrostat or levokitaconazole or other drugs. The other thing that I wanted to make a point for clinic, and that's very important actually, is for osilodrostat and also for metirapone, that's not approved in US, but it's used off-label. How you measure the cortisol makes a huge difference. So because, as I said earlier, with the mechanism of action, we have accumulation of precursors. If the cortisol is not done with LCMS, the cortisol could look normal. And that's the dangerous part because somebody can say, oh, this patient doesn't have adrenal insufficiency. And actually the patient has adrenal insufficiency because the precursors are measured. So that's another issue, that not all the labs are doing LCMS in US. So unless the patient is close to a lab that has LCMS, I would treat with steroids if I think that the patient has even potentially adrenal insufficiency.
Thank you. And then I'm just going to walk through a few other specific adverse events in this paper that are particularly clinically relevant. Cardiac abnormalities, including QT prolongation, occurred in 3 patients. All of those resolved. By week 12, 43% of patients receiving alidrostat experienced an adverse event related to accumulation of adrenal hormone precursors. So that most frequently presents as hypertension, compared to 36% of placebo participants. Looking specifically at adverse events in women, 36% of female participants with elevated testosterone at baseline did see an improvement at the end of the study. On the flip side, increased testosterone was reported as an adverse event in 29% of patients, and hirsutism occurred in about 10% of patients, all of which was suspected to be related to the study drug. And then looking at adenoma size, 21 patients had a macroadenoma and 50 patients had a microadenoma at baseline. 40% of patients had a 20% or greater increase in adenoma size. 28% of patients had a 20% or more decrease in tumor size, and the remaining patients did not have a significant change in tumor size at the end of the study. And I will hand it back over to Chase so he can walk us through the discussion.
All right, thanks, Katie. So we're going to start with what the authors state is their big conclusion. So to describe what they say is that osilodrostat rapidly reduced mean urinary free cortisol as early as 2 weeks in some patients, and the biochemical benefits of that agent over placebo were evident from week 5 onwards, with that primary outcome of a mean UFC normalization at week 12 achieved in a significantly greater proportion of osilodrostat recipients than placebo. That was 77 compared to 8%, as Katie walked us through already. So then what the authors do is they give us some comparisons. So I'm going to give you some different numbers as they look at other studies of different agents to try to see how it might compare, though there's going to be limitations because these aren't head-to-head comparisons. But I'm going to walk through some of these, and then we're going to circle back to Maria to help us sort through this data because there are many caveats with all of it. So first of all, the authors point out that there are a few other available medical therapies for Cushing disease that have been evaluated in placebo-controlled trials, and again, no head-to-head studies are available. So they mention another new agent that Maria's already pointed to already, levoketoconazole, that in a prospective trial that 31% of individuals are controlled after 6 months. They also mentioned metirapone, that in a prospective trial there after 36 months, 49% of individuals were controlled. And then in a retrospective evaluation that was done with that same medication, that 43% of the 37 patients had a normalized mean UFC. Also, to comment on pasireotide, the long-acting form of that in a phase 3 trial of that 35% of individuals were controlled at 12 months. Now, in other research, in particular around pasireotide, there was a suggestion that those individuals, those subjects who achieved normalization of both the mean UFC and the late-night salivary cortisol had better clinical outcomes than those who had only control of the mean UFC. So in this one, to go back and look at that, the subjects had normal late-night salivary cortisols in about 48% of the time, and then both normal late-night salivary cortisols and a normal mean UFC in about 45% of individuals. To compare that to some of those other agents that we've just mentioned, metirapone, an observational study, 37% of those individuals had a normal salivary cortisol, with the levoketoconazole, and in a phase 3 study that there was normal late-night salivary cortisol in only 4 individuals of the 94 that were studied after 6 months of treatment. And the authors also point out here is that in this study, that wasn't the focus of it. That dose titration decisions were made based on the mean UFC, and so even though this wasn't a target, it was achieved in a fair number of individuals. So Maria, comments on that? There's a lot of details, a lot of caveats with that, but how would you wrestle with all of that comparison data to try to help us figure out where osilodrostat needs to fit?
This was a very good summary, Chase. However, for Cushing's, that's why we say individualized treatment is key. If you talk to several experts and then show them the same case, their experience plays a role. And also when we compare, so this is very important to be familiar with the drug you're using. And also, what is the endpoint? Because yes, in the study, for all these studies that you had presented, with the exception of mifepristone, that you cannot measure urinary free cortisol, and it had to be the clinical endpoint, clinical improvement, diabetes, and hypertension. All of the others had UFC at endpoint. So of course, some of the salivary cortisol, not even all patients had salivary cortisol, though it was a secondary endpoint. And it's important to know that in clinic, and this is the question that I get the most from all my colleagues, which one you trust more? It's very hard to say. Both. If they are discordant, I want both of them normal. For adrenal steroidogenesis inhibitor, for example, we don't even know if we can really restore the circadian rhythm. I wish, but we don't know. This is one of the ideas behind combination therapies. However, going towards that, when I want to normalize the salivary cortisol, I go with a higher dose at night. And in some patients, this is improving the numbers and also improving sometimes their sleep. Is this a rule? No. I'm not the only one doing. Again, we had huge discussions at the consensus meeting that we have published last year. And this has been included as a potential option. It doesn't work for everybody. Clinical improvement, it's also very, very important, because when you're asking, and the question for you to me was how you compare with other medical therapies. I'm not just looking at numbers. Yes, in the study you have to. This was primary endpoint. Clearly, osilotrostat based on urine is the most potent drug we have. Now we have several other studies, including some extensions that we had recently published longer term. So based on UFC, osilotrostat has prospective data running against placebo, and it's the most potent one. This is followed by metirapone. The metirapone is not approved in US. We rarely use off-label, but it's approved in Europe, that has prospective and retrospective data. Then levoketoconazole, the study that was included here is because the other one has not been published at that time. The first one was open label. So again, you can't really compare because the inclusion criteria were completely different. The titration scheme was completely different. So the 31 number, you can't really take it and compare with this. A second study, randomized withdrawal against placebo, that showed that probably the response rate, if you really titrate well, would be about 50%. Again, clearly less potent than the other drugs, however, has different mechanism of action. So could be potentially a drug used for women that have hirsutism to begin with overall. If a patient has diabetes, yes, we've seen improvement of glucose in all these studies. And the same thing with hypertension. So yes, as I said earlier, the precursors are just tricking us because some patients will have significant clinical improvement with improvement of hypertension. Some patients could have hypokalemia and then increase hypertension. So we have to follow these patients very closely and not say this is a contraindication. I think the most important data of differences between short-term and long-term came from the long-term studies. So if we're looking for the latest 2 long-term studies on osilotrostat that have been published over the last 2 months, both of them. One was LINK-2, that we looked at patients that were treated for more than 6 years. Very few patients. This was a phase 2 study, and then we followed the patients very long-term. What was interesting is in women, the testosterone increased, and then towards the end of the study, normalized and went back to baseline. Yes, some patients dropped, but this was seen again in the LINK-3 extension. Over 100 patients continued in the extension from the study. And those patients, women specifically, their testosterone normalized and the hirsutism improved in most patients. So what we see short-term could be different clinically from long-term. The same thing for levoketoconazole, we saw hirsutism improvement and acne because, again, the mechanism of action is different and decrease in testosterone for short-term. So which one you need more? Diabetes improved in both studies. However, if a patient has severe diabetes, I would probably use mifepristone first, though longer term could not be a good option for a woman because of vaginal bleeding and other issues. Other new glucocorticoid receptors are coming without progesterone effects. So overall, it's very hard to compare drug versus drug, but we have to have in our mind biochemical efficacy, clinical efficacy, adverse effects, and let's not forget about tumor. Pasireotide, you mentioned earlier, yes, overall, the response rate just for urine was 35% at 12 months. But if you look in the details of selection for patients, several studies show that patients that had less than 1.5 and 2, so mild Cushing's, responded 50%. So for mild Cushing's with large tumor, I would probably go first line to a drug that works at the pituitary level and see if I see some shrinkage, but not if the patient has diabetes, because if that patient has diabetes, the likelihood of developing worse diabetes is almost 100%. So we need to think about all this, but patient-reported outcomes are very important. Quality of life increased in all these patients that were treated, but it's important to remember, did not go back to normal, and sometimes could not go back to normal overall. The only drug that I haven't mentioned is cabergoline, that again, it's not approved in US, it's used off-label, but it's not a very potent drug. I usually use in combination if I really need something at the pituitary level, and we have to remember that it has significant effects on impulse control disorders, valvular disorders, at the doses we need to use in Cushing's if it's a single treatment. And then now we have approved levoketoconazole that we have talked about because we had multiple prospective studies, but ketoconazole is still used off-label in US in a lot of patients. So we shouldn't forget about that and how to monitor these patients. We have no prospective data for ketoconazole as we are right now. And then the one thing that we didn't talk about is changing in treatment. And this was a study. So if the patient wanted to get out, went out. However, in clinic, how I usually do it, I tell the patient from the beginning, we know, for example, for pasireotide, I'm waiting about 2 months and we kind of know who's not going to respond. Of course, not in severe Cushing's, but in mild Cushing's that we control the diabetes, we control the hypertension, we put the patient on anticoagulation for hypercoagulability. So we do deal with all the complications. I'm waiting to see if the patient tolerates, then I'm going to optimize the dose. And I'm not going to talk about titration specifically right now, but I would not consider resistance to treatment overall until we really went to the right dose that's tolerated by the patient. And then we really have to close monitor what we're trying to achieve before switching. Sometimes we need to add a treatment.
So a few final comments here. The authors point out that osilodrostat was generally well tolerated and very few individuals actually stopped the agent because of an adverse effect. Hypocortisolism did happen, not a surprise because of the mechanism of action. But they do point out that it happened much less frequently. It's only 27% of the time in this study compared to a previous trial of osilodrostat where it happened 51% of the time. And the authors speculate that may have been because the dose escalation schedule was slower here. It was every 3 weeks as opposed to every 2 weeks in that previous study. Now, a few other strengths that the authors point out. So they point out this is a randomized placebo-controlled trial and nearly a year long of treatment duration, so an obvious strength there. They also point out, as Maria walked us through earlier, that there were very strict entry criteria, so they were able to confirm that everybody had Cushing disease as a requirement to participate in this study, and also had that robust treatment effect that was monitored by those numerous mean urinary free cortisols throughout the study. A potential limitation that they point out is that though there was a very extended duration of observation, that it is possible that those adverse effects may take longer to be observed. And as we talked about earlier, that's the potential role of a phase 4 trial. Even though we may not have a lot of patients with that, we could at least get a lot more time that would help some of those show up. So now we're going to end with thinking about whether this should change our practice. And first, I'm going to go back to Katie, and I just want to get her sense as she helped analyze this article. Katie, what are your thoughts about the quality of this report, the strength of this report overall?
I think it's a good study, both in terms of patient selection and then in terms of the medication. I think there's a lot of benefits for this medication, both being an oral medication, which is always a plus for patients. It's reasonably well tolerated. It's reasonably effective. I think compared to some of the other steroidogenesis inhibitors, there's not as much data in terms of more rapid dose titration. So the patients on average achieve normal urine-free cortisol after about a month, whereas, in patients that have more severe Cushing's disease or ectopic ACTH secretion, you may be wanting to use a medication that you can more rapidly titrate to achieve a normal urine-free cortisol. But I thought it was a strong study overall.
So I'm not going to comment directly about the study. I wanted to point out that talking about how quickly you can achieve control. And this was not done in the study, but we do in clinic. And we're using, again, it's off-label, block and replace. So you can use a higher dose, block immediately the cortisol secretion if the drug is tolerated, and then give additional hydrocortisone, or I usually do dexamethasone so I can continue to check the cortisol. So for ectopic Cushing's or very severe Cushing's, this is the way I'm doing it. We haven't published our data, but it's a French study looking at that, and all the patients with severe disease were controlled. This has been done before for patients on triple therapy. So we could think about that. It's less used in US compared with other countries. But overall, I think we are getting there. We have more medical therapy options. I told you we have 4 in the last 10 years. So I think we're doing well. The studies are getting better and better. Randomized studies versus placebo, longer term, larger number of patients. What we need to do, and the studies cannot be better than our collective experience, unfortunately, is to determine the biomarkers for control. So we don't really have for disease activity or control, both before getting into treatment or after that, because of the large variability between patients. And as I said earlier, and I know I sound like an old machine, but if we make efforts to have an earlier diagnosis, then the patients would not be so complicated, and we can treat them better just with surgery or with one medication that will clinically improve also, not just number. So definitely we have to look into the management of long-term complications that we're not doing very well. And in addition to what I mentioned earlier with better biomarkers, the restoration of circadian rhythm would be very interesting to look at, especially for these potent drugs we're doing with higher doses, but might be a different regimen that we need to do. And then this was very few patients for this study because 88% had surgery. But what would be the benefit of preoperative medical treatment? During COVID, I have used more preoperative medical treatment, not to look specifically like we did for acromegaly. Is this impacting the surgery outcomes as efficacy? Probably not. But can we improve their clinical features and status, and then they will do better with surgery? So that's also something else that they do more in Europe and they have looked at, but retrospectively, it's not exactly the same thing. And longer term data, definitely we need even more. Yeah, we have few patients to 6 years, 100 patients up to 4 years. So things are progressing, but we need to see facts as the authors of this study. And we also said many times in all our research that looking at the MRI changes years and years later would also be important for this type of drugs. Furthermore, we had some increased knowledge in genetics of Cushing's disease, but not as good as adrenal Cushing's. So it's possible that we'll have some drugs that works directly for a specifically type of tumor mutated. It's one study showing pasireotide might work better for some, but this has to be validated in larger studies. Cushing's quality of life to be assessed not through what the doctor says, through what the patients say with patient-reported outcomes. And new therapies targeted at the pituitary level. There are few phase 2 studies with salicylib right now that was recently published in GCM. It's a very small study, but working at the pituitary level, again, you have to look at what's the effect for a phase 2. It's a very short study versus adverse effects. There are some preliminary data, mostly on animal model, on gefitinibib, again, with EGFR, going to possibly to some patients if we'll know the genetics. So I think the future looks bright. And this study adds to our knowledge of potency of drugs and looking in a completely different landscape than our clinical practice all over the world.
And with that, I would like to thank Katie Gutenberg and Maria Flescheriou for joining me for this month's edition of Endocrine Feedback Loop. I learned a great deal and know that you all did as well. Please join us again next month. And now you're in the loop. This has been Endocrine Feedback Loop. Endocrine Feedback Loop is brought to you as a members-only benefit of the Endocrine Society, with production oversight by Brandy Brown and Andrew Harmon.
Hello, I'm Aaron Lohr, host of the Endocrine News Podcast. In addition to bringing you the latest research breakthroughs and clinical advances from experts in the field, we talk about education, advocacy, career growth, and more from the endocrine perspective. From bench to bedside, from graduate school to practice, from the doctor's office to Capitol Hill, we talk about it all, and it's free to you. So go to www.endocrine.org/podcast or search for Endocrine News Podcast on Apple, Google, or wherever you get your podcasts.